Well, welcome to the Encephalitis International Podcast, or it could be Encephalitis International Podcast, depending on where you are in the world. In this edition, we're going to be talking about improving the diagnosis and treatment of encephalitis in low to middle income countries, something that we feel is a really important topic at Encephalitis International. Of course, as ever, if you're affected in any way by the content of this podcast, then we have support available, as you know, and as always, you can find helpful links in the description of this episode. I'd now like to welcome my guest, Dr Bhagteshwar Singh, or Bag, as he is fondly known by many of us. Bag is back in the UK, having been based at Christian Medical College in Vallor, India, and Queen Elizabeth Central Hospital in Blantyre, Malawi, in the last year. He's also a clinical research fellow and specialty registrar in infectious diseases and general internal medicine at the University of Liverpool in the UK. So as you can see, he gets around a lot. Bag was also very much the driving force behind a study that I was lucky enough to be involved in, which was called Brain Infections Global. And it's this which we're going to talk about today. So welcome to the Encephalitis Podcast, Bag.
Thank you so much, Ava. Privileged to be here, as always.
Well, we should start, I guess. Just tell us a little bit about yourself, Bag. Just give us some background.
Sure, thanks. So I'm a doctor specializing in infections, and I also do general medicine. And for the last 6 years now, I've been doing quite a bit of research, and as you say, primarily on brain infections and how to improve their diagnosis in low and middle income countries. And yeah, I've been based mostly in India, but also bits of Malawi and Brazil, where this research group was based and where our study was running in the last few years.
Well, let's talk a little bit about that study, which has got a very long title, which I'll spell out for everybody. But it was called Improving Diagnosis and Early Management of Hospitalized Patients with Suspected Acute Brain Infections in Brazil, India, and Malawi. So if you could give us a really brief summary, what was that study about?
So people with acute brain infections, as we lump them together, but encephalitis or encephalitis, as Encephalitis International focuses on, and this podcast focuses on, is one of those. Meningitis is another. They're really severe infections which can cause death, and also among survivors can cause long-lasting severe problems. And they're quite challenging to manage, partly because we struggle to make a diagnosis to make sure that that someone, for example, definitely has meningitis or encephalitis once we think they might, and therefore not something else, and then we focus in on that. But also, most people with encephalitis or meningitis, it's due to an infection or a bug, and finding that bug can be really tricky because of the nature of the infections. And it's even more tricky in places that don't have as good access to healthcare as we do in the UK. But unfortunately, these infections are often more common in those places where we do have limited resources. So this study decided to tackle that challenge, trying to improve management, but starting with improving diagnosis so that clinicians are more certain about someone having one of those brain infections and what's causing it, so that we can tailor management to it and then hopefully improve outcomes for those patients.
Well, give us an example maybe of one or two of the interventions that the study produced, and in particular, did those interventions fit all of the countries that you were involved in across, Malawi, Brazil, and India, or did you have to tailor these interventions? Tell us a little bit about that.
Sure. I think one big challenge about what we set out to do was that the situations were very different in each of the 13 hospitals in the three countries. And you can imagine that, on different continents, everything will be different. Climate, the bugs which cause infections, the ability of people, or how kind of people access healthcare. So really, ideally you would set up an intervention that's very different in each place. But what that would do is maybe deal with the issues within that one hospital, for example, but we wouldn't be able to then just take that intervention and use it somewhere else. And so what we tried to do was put something together that would work across everywhere to an extent, with an overall structure that then everyone kind of was singing kind of from the same hymn sheet in terms of overall aspects of this intervention, but each individual bit was then tailored to the needs of each hospital and the challenges that we had found in each hospital, and the hospital's potential to do things. So an example would be part of our intervention was putting together a collection of tests within each lab. But some of the smaller hospitals had more limited equipment and other, and even, I guess, expertise amongst the staff in the lab. And we knew that they wouldn't be able to do really complicated or really expensive tests. But each of those smaller hospitals was linked to a larger hospital where we could then do some of those tests. But also for some bugs, you have versions of tests that can be used in smaller hospitals and without as much equipment. So while we might have been testing for the same bug in a few hospitals in a country, we may have, for some of those, used a different test, or at least initially a different test in the smaller hospitals. And for some of the bugs, we would have done the test in a different place. And part of the intervention then was to sort out the transport of samples from the smaller hospital to the larger hospital. So rather than just the test itself, it was also how to make sure the test is available, how to make sure the sample gets to where the test is available, rather than just that one test being put into a hospital. I hope that gives you an idea.
Yeah, sounds complicated, but I mean, I guess in the same vein, were there any challenges in ethics and standards across the three countries? Because as I understand it, and obviously I worked with you a little bit on this project, they're three really very diverse healthcare systems.
Yeah, that's right, and obviously each country, each hospital, needs to tailor what they do to the population, to the culture of the patients they're serving. And so we did find it somewhat challenging to make sure that, for example, the protocol or the plan for the study worked in terms of the legal requirements and the ethical requirements in each country. And what we really, I mean, I think we wouldn't have been able to do that unless our team included people who've been working in these countries for years and years, and who knew those principles and rules inside out, and could guide us on that. And we got everyone together to discuss these issues, including you, to make sure that what we were planning would be relevant everywhere. And we made sure we got approvals from the ethics committees and other regulatory bodies in each country, and that the overall protocol was approved everywhere. So we then had a plan that was the same everywhere, but worked everywhere, so to speak, in terms of the requirements. One thing I should mention is you, Ava, you looked at everything that we did as part of the steering committee, but you also made sure that the patient and public involvement panel that you led fed into specific areas that were of importance and relevance here. So, for example, the consent forms that we made were, we made sure that patients and their relatives and patient representatives had vetted them and even edited them to make sure that they're really understandable. And that's really important. You can't ethically do something, in terms of research without patients really understanding what's going on, and the consent form and the information form or leaflet is really important, a really important part of that.
I remember it well. How are the different healthcare systems funded across the three different countries? Give us a little bit of insight into that.
Sure. So this differs from country to country throughout the world, and our three countries, Brazil, India, Malawi, were no different in that regard. I guess one difference is that Brazil is very much an upper middle income country, India a lower middle income country, and Malawi a lower income country. And what that kind of means is that the buying power or paying power of the public will be different on average, and there'll be larger sections of the population who can afford private healthcare in Brazil and India than in Malawi, and so a bigger proportion of healthcare is provided by private hospitals in Brazil and India than in Malawi. We really wanted to capture this somehow, so we made sure we included some non-government hospitals in among the 13, and they were they were non-profit, they weren't commercial hospitals, so to speak, but one of the differences, I guess, was being able to put things in place. So as you know, governments are really big, complex organizations, and getting approvals for changes within a government service can be quite challenging. And though from the outset, which you were part of, Ava, we had a policy working group which made these things easier to an extent. But I think it was interesting to see how some of the private hospitals could just overnight say, yeah, we're going to start doing this, whereas in the government hospitals, sometimes we needed sign off from central government or state government officials in order to make things happen. So that did influence how we approached the study.
Honestly, I mean, I listened to it all now back, and I know I was involved, but I still don't know how you negotiated all of this. I genuinely do not. So, yeah, I mean, I take my hat off to you. It was. I used to look at you in awe back then, and I still do when you talk about it now. But anyway, enough of my fangirling you or whatever it's called.
But also I should say that it's the team.
It is the
we
team.
had people in each place who knew who needed to be spoken to and how to make things happen.
Yeah.
And we were really lucky in that way.
There was lots of people. Did you ever count it up? Do you know how many people were involved? I never did, but it was a lot of people.
I think there are nearly 200 authors of the manuscripts or the paper we've submitted to the journal recently. So that gives you an idea.
Wow. Okay, well, let's turn to some of the results and findings. Just remind us what the primary interventions were. The kind of there was an algorithm, I think, a lumbar puncture pack, that kind of thing. Tell us what they were and what the primary results were, and then we'll talk a bit more.
Sure. So there were four bits of the intervention that went in place everywhere in one way or another. And some places did have some additional components within that intervention. As you said, well, as we mentioned earlier, and I won't go into much more detail about it, there was the diagnostic test panel, which brought together tests that were already there or brought in some new tests to make sure that we could test for each relevant bug, especially the common ones and the treatable ones, and starting with those, and then also looking for some of the more rare ones if we didn't find one of the more common ones. As you say, there was a clinical algorithm. So up on the walls in key places like emergency departments and intensive care units, but also on people's phones, we sent round an algorithm that people could refer to really easily to work out what to do with the patient in front of them in terms of trying to make a diagnosis and giving the right medicines and other management aspects as well of care. The lumbar puncture pack. So as many of the people who are watching this podcast might know, that's a procedure to try and get cerebrospinal fluid or fluid that bathes the brain and spinal cord. And that's critical in trying to make a diagnosis, particularly in meningitis and encephalitis. And it's not easy and requires a lot of fiddly bits of equipment. And so putting all of that in one place and providing some guidance on how to do it was a key part of the intervention. And then finally, training everyone, partly in just, how to diagnose and manage patients with possible brain infections, but also how to use all of this that we were putting in place was essential to make sure that staff, both in clinical areas and in the labs, could effectively, deploy the intervention, so to speak. And sorry, the results you asked for. So what we were primarily looking at, as I mentioned earlier, was diagnosis. And there are two bits of diagnosis. So can we define a syndrome? So can we say this is meningitis or encephalitis or something else with confidence? So a syndromic diagnosis. And then we had microbiological diagnosis, which was, can we define that bug which is responsible for the brain infection? Or for maybe another infection that can sometimes look like a brain infection. So with that syndromic diagnosis, about 3/4 actually of patients were already, before we put the intervention in place, receiving that syndromic diagnosis. And we increased that from 77% to 86%, which we found using the statistics that the analysis that we did, that was a significant increase across all of the hospitals in all three countries. With microbiological diagnosis, we started at below 1/4 before the intervention. And then after the intervention was in place, that went up to nearly 1/3. So from 22% to 30%, which sounds very low, and it is. But we kind of knew from the outset that this is quite a challenge. And again, that looked like it was a significant, as we call it, increase.
Mm. Do you think that the intervention had kind of any impact for patient outcomes beyond diagnosis, kind of what we call their functional outcomes, or even do you feel that it meant that they got, therapy quicker,
Sure. So while the primary aim was to try and increase the number of people getting a diagnosis, the end goal with all of this research that we do is to try and make people's lives better and to prevent people from dying. But we knew that with what we were doing, the first step was to make a diagnosis. The next step then might be to improve the ability then of clinicians looking after patients to manage them better. But maybe sometimes they go hand in hand, and then together they then hopefully will improve actual outcomes, as you say. So in terms of those sort of markers of how well we were managing patients, we did have improvements in some of those. So in terms of, for example, the time it took to get the right medicine, which was given preferably at the front door, as soon as the patient was assessed, should have been given. We found that wasn't being given as quickly as you'd like before the intervention, and was being then given more quickly after the intervention went in place. And you'd hope that then would improve the chances of that patient surviving or surviving without ongoing problems. So we didn't expect to show an improvement in, as you say, functional outcomes, but the way in which we measured that was using the Liverpool outcome score, which looks at, it was actually designed for encephalitis, but has also been used for meningitis. And we looked at whether people could do things for themselves after the infection, how well they could do those things, and whether they had any other symptoms that were limiting their ability to live as they would like to. And there was, we think, a small improvement in that, both when we measured it at discharge from hospital and then when we followed people up to about a month later. There seemed to be an improvement after putting the intervention in place. We're a little cautious about this because obviously we didn't set out to show that. We didn't think we would be able to show an improvement of that sort, but also the improvement wasn't huge. And this is where kind of some of the things that you show through research need to be replicated with other similar research in order to be more sure about it. And we think this is one of those things. But it makes us hopeful that what we were doing might actually have made an impact on patient outcomes.
Were there any significant differences in outcomes across the three countries?
Yeah, so as we said earlier, we had to tailor the intervention to each place, and sometimes that's what goes into the intervention in a really obvious way, like how the lumbar puncture pack looked, or how the clinical algorithm, what it advised clinicians to do, but also sometimes that involves how the intervention is implemented in each place. And because there's so much variability in that, and how a health system or a hospital differs and therefore might influence how something works, we expected to find differences between each place. What was really nice was that overall there seemed to be consistency across all of the hospitals and countries overall. So while some of these things, like say the syndromic diagnosis or microbiological diagnosis, or the amount of time, maybe we were shortening that time that patients wait to get the right treatments, might have differed in each place to an extent. Overall, there were improvements everywhere, and that is reassuring. Did you want an example specifically, Ava, or?
If you want to give one back, I don't mind. I've got plenty more questions for you, but
sure. Well, I mean, just maybe we can move on then, and maybe an example will come through,
Sure.
in something else.
So do you think that what's happened in this study, can it be rolled out to other low and middle income countries?
So I think that point I made about overall consistency across the different countries and different hospitals, where we were working in very diverse environments and with diverse patients, I would say hopefully yes, that in itself means that this is something that can be used in different places. I think that the point I made earlier about there being an overall structure and that kind of worked everywhere means that it's something that could be followed without it looking too complicated. We've got those kind of 4 key parts of the intervention that I mentioned earlier. I think also we've tried to describe some of the insights into how things differed in each place, and how we went about tailoring the intervention to the needs of each place. And we've got on our website, we put all of the tools for all of the hospitals for these bits of the intervention all in one place, with a document that provides guidance to clinicians who want to try and put these tools in place in their hospitals. And also, I think it's really important for fellow researchers to try and, see if it is working in other places as well, and what modifications might need to be made. So all of the tools are put on not just as PDFs, but in formats where people can actually adapt the tool to what they need, and a bit of guidance as to how to do that. The other thing, I guess, is we are very willing to work with people on deploying these tools in different places, and in fact already some people have been in touch, and I've been talking to them to try and support them with that, which I think is really important. If you know the tools really well, then it's your responsibility, I think, to then help others to use them.
Yeah, that sounds amazing. We'll try and put a link as well at the end of this podcast to the tools that you're talking about, so to make sure people have got a kind of one-click easy access. Are you going to be kind of tracking what went on in the hospitals that you worked in, and the interventions you put in place over time, or is that it now? Is the study done?
Well, we talked earlier about the team, and one of the big outcomes of this study, which often isn't talked about much, is the fact that we have this brilliant team of really committed, enthusiastic people who are also experts in this area. And we're all talking about how things have worked, how things can be improved. Ava, you were a big part of supporting the use of champions in all of this, and we had a dedicated person, or even more than one person, sometimes per hospital, who was responsible for driving the intervention and helping people troubleshoot bits of it and maintain it. And those champions are still on board and keen to move things forward. So and similarly, the kind of the leads of departments and hospitals and the wider health system, we're still in constant dialogue with them, and they're keen on adapting things within their own setting to make sure that they continue beyond this. So sorry, long answer that translates to yes, we definitely are, and we're hoping that this network expands so that we can track it, but also is really important to make sure that we evolve with or adapt to changing needs within each hospital, which is inevitable. And I think we've got a strong team that's going to enable that.
Well, that's exciting times, and I think that fits really nicely under the global work that we're trying to drive forward as well. So hopefully, there'll be more collaborations to come, and we can, make a bigger difference in other places too. What do you think? What further research is needed in this area, in this field?
So this could be a very long answer because I think there's a long list, but I'll try and keep this brief. So I think going back to discussing those tests for relevant bugs or pathogens, I think there's still a lot of work to be done there, and there's lots of work happening on making new tests, but how to use them in a way that actually benefits patients. So more about the implementation or deployment, or how they're used, and maybe in which order, and maybe which one of the tests do you use in one place versus another. I think there's not enough research on those aspects beyond just how well it works on a sample within a lab. I think on the management side of things, as you know, Ava, there's a lot of uncertainty about treatments for both encephalitis and meningitis, and there is work ongoing on especially how to address inflammation, or the body's response to something not quite right when it comes to the brain. We don't really know whether to use steroids or to use other drugs to dampen that down. And which patients would benefit from each of those. And I'm glad that there's work ongoing there. But I think some of that work isn't tailored to the needs of some of the infections we see in lower resource settings or in low and middle income countries. So I think more tailoring is needed there. And then I think finally, this is, I know, close to your heart and work, Ava, but longer term care and working out beyond what we did, focus very much on once the patient had come to hospital. And I think there's aspects of how they get to hospital and that needs to be focused on. But beyond discharge from hospital is very unclear as to the extent to which people are affected and how that can be tackled. And I hope some of the work that we're working on will address that in due course.
I agree. And of course, what is important to patients in one country can often be quite different to what is important to patients of another country, as I found when I joined you guys in India and Malawi, and that was really interesting. You talked about meningitis, you talked about encephalitis, and we know that the World Health Organization has this intersectoral global action plan, as they call it. And they're also doing rolling out something called the meningitis roadmap. So their global action plan was originally, I think, designed for epilepsy, but they're including all neurological disorders, or expanding it to include neurological disorders such as encephalitis now. And of course, they have this ambitious project, the meningitis roadmap. And obviously, Encephalitis International is working with them at the moment and funding a technical briefing, which is a policy document which we will be launching for World Encephalitis Day next year. Do you think that the WHO or any other key stakeholders are going to be able to use the findings from your study? Are there any plans for that?
I hope so. I mean, who doesn't want their work to feed into international policy? But also, what we really wanted to do at the start of this project was to make something that could be used across the globe, but focusing on low and middle income countries. And obviously, the World Health Organization, that is the priority for them. And so it's been great to be able to feed into their work, which we are doing at the moment. That they thankfully have taken note of our results, and we're working with them to work out how we can feed those results into those initiatives that you've mentioned. I was lucky to be invited to Geneva in July to present some of the results, and to work with other researchers and policymakers and people who deliver services to try and see what's relevant within our results to take forward into quite broad policy initiatives like you've mentioned, this intersectoral plan, which goes beyond meningitis and encephalitis. So yes, we're feeding in, and it's really exciting, and makes it feel like it was all worth it.
Yeah, no, it was definitely worth it. Do you know of any plans for guidelines or protocols, or do you think this is going to fall out of this intersectoral global action plan for managing brain infections, especially in low to middle income countries?
So I think while it's really exciting to feed into these international policy documents, they tend to then be put out there for then national governments or local hospitals maybe to consider. And then they start their own work that's most relevant to the patients they see. Whereas it's been great to obviously kind of have what we put in place continue within each individual hospital, and form official guidelines within each hospital. But in India, we've already started supporting a brain infections guidelines project for the country, which is being put together by the national professional organizations for infection and for neurology, as well as input from the pediatrics national organization. So that's been really exciting, because I think that hopefully then would be available to clinicians much sooner than what kind of comes from the really high level policy documents, to then informing things that are more practically useful off the shelf. And we've had similar conversations with colleagues and policymakers in Brazil and Malawi who seem really interested in this sort of thing. But I think it's great for India to be sort of taking the lead on that and showing the other countries kind of what can be done. And as we said earlier, each country needs to work out what is best for them, and it's nice to be having those conversations.
Yeah, absolutely. Well, we're coming towards the end of the podcast. I'm sad to say it's been a pleasure talking to you, but is there anything else that you'd want to tell this audience about your work or the field of brain infections, and I guess, tell people a little bit about maybe what you're currently working on, and where people can find out more information?
Sure. Thank you, Ava. So you mentioned earlier about putting a link on here to the website, and that would be great, because then everyone can see the tools that we'd put together and use them. I guess in terms of other work that we're doing at the moment, as I mentioned to you before this podcast started, Ava, I just submitted my PhD thesis, which is a massive relief, weight off my shoulders, but also yeah, has been quite a journey, as this study has. And part of what's in there is not yet out there for people to see, and so part of my focus is to try and publish the other studies that I've done alongside this brain infections one that we've worked on. The other big thing we're working on just now is trying to work out if the approach we've taken for brain infections could be used for other infections, and particularly other severe infections that affect people who come to hospitals in low and middle income countries, and to see if some of the tests that we were doing for bugs that were more common and then also less common, I hope they've also informed people on what causes brain infections, and have, making those last beyond the study within the labs means that we can track those infections over time, and that can be really important to try and find out, how things need to change in terms of the care we provide over time, but also potentially detecting outbreaks, and those outbreaks of maybe infections that are emerging and might lead to bigger outbreaks and epidemics and even pandemics. And so trying to harness the potential value of those tools that we've set up for that purpose is something that we're looking at, in addition to using the tools for improving diagnosis of other severe infections in low and middle income countries. So watch this space for that. In terms of where to find out more, thank you again, for putting the link to the website on there. And of course, people can look at my University of Liverpool webpage as well, to see other work that I've done if you're interested.
Fantastic, thank you. Well, is there anything else that you wish that I'd asked you, or that you want to add before we close the podcast today?
Not really. Thank you, Ava. It's been enjoyable, and one thing I should say though is that being involved, being able to work hand in hand with an NGO that is doing such great work for patients with encephalitis and other brain infections is it's been eye-opening these last 6 years to see how that can really help the work that we're doing in terms of research and maybe clinical work as well, translating that into something that is accessible to people who might be suffering from encephalitis or the after effects of it, and the people who are near and dear to them, and just how that kind of partnership can be really valuable. So thank you so much for involving me in all of that, and I look forward to meeting you in London when very kindly the Encephalitis conference organizers have invited me to speak a bit more about the brain infections global study.
That's right. You are one of our keynote speakers, and very thrilling it is too. So we're going to be delighted to have you. But thank you for those kind words, Bag. And thank you, Bag, for taking the time to drop by the Encephalitis podcast today. And congratulations again on such a fantastic study. It was a real pleasure for me to be involved in this study. And I know we all had our challenges at times, not least of all the global pandemic that plopped into the middle of the study, which was already an ambitious study. So, I think it's just been an incredible collaboration, and I've been very proud to have been involved in it. As I mentioned in my introduction, Encephalitis International has a number of resources that are available to anyone affected by encephalitis. Our support team are a great resource, which I would highly recommend any of the listeners take advantage of if you've got any questions or if you simply want someone to talk to. You can find all the information that you need in the podcast description. As always, if you can support our work, we would be extremely grateful. Please visit encephalitis.info/donate. We are here to help, remember, everybody, and thank you all very much for listening to yet another edition or episode of Encephalitis International's podcast. Thank you.